So I'm Donna Barrett. I'm a licensed social worker from Summit County Public Health and the program manager of senior and adult services at the health department. I'm going to talk to you today about one of our programs. It's called the Gatekeeper program. And it's really going to be like a mini training, so you get an idea of what we do. I'll talk about who we train, how we get our referrals, and what happens after we get a referral from the program side. So just a disclaimer, this project is supported by a grant numbers there, from the Department of Health and Human Services, Administration for Community Living, Administration on Aging. The view and opinions expressed in this PowerPoint presentation are those of the presenter and not necessarily of the presenter's organization, including the U.S. Department of Health and Human Services and the Administration for Community Living, Administration on Aging. So we'll start by talking about what the Gatekeeper program does. The Gatekeeper program systematically locates and identifies at-risk elders, particularly those who are isolated, living alone, and in need of some type of assistance to remain safe and as independent as possible in their own homes. For this grant project, we aren't just looking at-risk older adults, we're also looking for specifically people who have suspected or known dementia. Our focus is really identifying those folks that are living alone in our community who have a known or suspected dementia, and also their caregivers. And we are also targeting folks that have intellectual and developmental disabilities that also may have a known or suspected Alzheimer's disease. So why are we doing this program? Well, first of all, we know that the national aging numbers are increasing, and we know in Summit County that by 2030, we could have a population that's about 20% older adults, and a significant number of those folks will or may have a dementia type diagnosis. Our local aging numbers, again, we expect that they're going to be about 20%, which would be 1 in every 5 people will be an older adult. There's lack of programming that systematically identifies at-risk elders in our community. And this program has been known to be successful in identifying at-risk folks, getting them linked to services, and keeping them in the community for a longer period of time. We have support from our partner agencies. So the GWEP is one of our partner agencies, as well as the Benjamin Rose Institute on Aging, Direction Home Akron-Canton area on Aging, Akron Metropolitan Housing Authority, and then we have a few local and state partners who work with us on other aspects of our programming. So what is a gatekeeper? Well, a gatekeeper is a non-traditional referral source. When I think about, as a social worker, who I would typically get referrals from in a hospital setting, or here at public health, it's typically somebody who works in a healthcare setting and sometimes family. But what a gatekeeper is, it's a traditional referral source who, through their daily job activities, may come in contact with one of these isolated older adults, or folks with dementia that are even younger, and identifying them as somebody who needs assistance with their physical health or mental, emotional health, or even social support assistance. So it's a non-traditional referral source. So who are gatekeepers? Well, a gatekeeper can be any employer of a corporation, business, and any other organizations that have contact with the most isolated older people in our community. So here's a few pictures of who gatekeepers could be. And, you see a lot of first responders up there. That's where we think of people, calling in. They see people on a regular basis, especially the fire department, EMS people. Utility meter readers go into the home. They may identify somebody who's at risk or confused, and they may not know what to do with that person. And, part of our role is to get out there and train these gatekeepers so they can be our eyes and ears in the community to help us find these more at-risk people. So here's a list. It's not an inclusive list, but as you see here, it is first responders. It could be apartment managers, those utility people, telephone companies, the post office. I was out at doing a mini training out in one of our cities in Summit County the other day, and one of the postal workers actually asked me about training the post office, so I'm waiting for him to call. Bank personnel, cable companies, Meals on Wheels volunteers. These folks actually probably see the older adult on a daily basis, and they might be able to identify changes in this older person that might indicate that they need assistance. Outreach workers, transportation, senior center, parish nurses, churches. I've not had any hotel or motel people refer folks to me yet. But when I did this program in a different county years ago, we had a few people that were clients that lived in the motels and had lived there for years. Local building and service departments, we do get referrals from those folks. They're identifying people with hoarding conditions or conditions in which they can't take care of their home any longer, and pharmacists. So what is the role of the gatekeeper? Really, the role of the gatekeeper is to recognize the signs and symptoms that indicate that somebody needs assistance. So they're really keeping a watchful eye while they're doing their daily jobs. And I like to say that these gatekeeper volunteers are our eyes and ears in our community. We cannot find these people without their assistance. And then their job is to refer to us. We don't expect that people who are out doing their daily jobs take on the role of, be the social worker or the nurse or the counselor. That's our job. We just want them to be able to recognize while they're doing their jobs that somebody needs assistance and then refer to us here at the health department. So here could be a gatekeeper referral. So what are the reasons that somebody should be looking for? What are those signs and symptoms or reasons to refer? And so physical changes, and maybe, you've been working with somebody at the senior center. They come in all the time to your senior center. They've been coming for 5 years, and all of a sudden, you've seen this change in them, or it's a gradual change where they're not keeping themselves, clean as well as they used to. Maybe their hair's dirty, or their clothes are dirty, or they're starting to smell badly from not taking a bath. Maybe this person's having difficulty walking, and they're not using a walker or a cane or any type of, ambulatory device to help them walk safely. Maybe they're a person who has frequent falls. So we get referrals from our EMS for those folks that are having frequent falls. They think that the person needs some assistance in their home to stay safe. It's an appropriate referral. Or any person who's resisting care. Maybe you're somebody who's working with this person in a hospital setting. You're seeing them and you're suggesting that referral be made to, the area agency on aging, or the person should be going into a nursing home facility and they're refusing to do that, but they still have decision-making capacity. That would be a reason to refer to the program. Other conditions that gatekeepers may see is the condition of the home. And so, like I said, we get a lot of referrals from housing folks because the home needs to be repaired. There's a hoarding condition. Maybe the grass isn't being cut or the yard's being neglected. Maybe they have pets that are chained up outside, or maybe they have pets, 20 or 30 pets in their house that are not being taken care of. And that's, making the house not smell good, and it's not safe for either the pets to live in the house or the older person. Old newspapers piling up. When I talked to the post office person the other day, he talked about the mail piling up. They notice when the mail's piling up, and what they've been able to do is just call the police department to have the police department to do a well check, but they want to be able to do something else. Maybe the person can't get to their mailbox or they need some assistance. So they want some other resources to help this older person. Again, the garbage is piling up outside, cat litter is not being changed. Those are all a sign or a symptom that somebody needs assistance. Economic conditions. People are confused about their money. They don't know what their money is. They don't know how to pay their bills. They're forgetting to pay their bills. They have shutoffs on their bills, or maybe their utilities have been shut off. They can't afford food or medication or transportation. And even with, prescription drug assistance programming out there, there's still people who are choosing to have to buy food over prescription medications. And maybe these folks need to be linked to prescription assistance programs. Or they can't get out and get their prescriptions because they don't drive and they may need linked to SCAT. Other reasons include, no caregiver or support system. A lot of the folks that we get referred to us who are living alone with dementia actually are people that really don't have a support system. The caregiver may live out of the state. There may be discord in the family and the caregiver doesn't know what else to do with the person. So that would be a reason to refer. Maybe the person living in the community is isolated from others. They don't go out into the community. And as a gatekeeper person or whatever organization that you work for, maybe you're the only person that sees and has noticed this person and you've recognized they need some help. And of course, those people that live alone who are having difficulty managing their life, their daily life, and have changes in how they're functioning, both physically, cognitively, and emotionally. Other reasons to refer could be changes in speech and language. We see a lot of folks with Alzheimer's disease. They have issues with word finding. They can't necessarily communicate or hold a conversation. They repeat questions a lot. So any of those patterns that you're seeing, especially with that person who may have dementia, and you're concerned about them, that would be a reason to refer. Emotional issues, they're depressed or anxious. There's caregiver stress. Through our program, we work with caregivers. We have another component of the work that we do. It's the BRI care consultation program. So we can link caregivers to that program where we're providing support, mentoring, and coaching them. The person is withdrawn or nervous, the person that you're identifying, maybe they're excessively reminiscing, or they've talked to you about not being able to sleep or not being able to eat. Memory and confusion, because our project is really focused on trying to find these folks specifically. If a person's getting lost in familiar places, wandering outside the home, they're confused or forgetful. I get referrals from some of our doctor's offices because the person is calling, every day to check when they have their next doctor's appointment. That might be a reason to call. They have trouble with time. They're not oriented to time. They have poor judgment and decision-making. And one of the cases I'll talk to you about in a little while will show that. They've had mood, personality, or behavior changes. They're unable to perform familiar tasks. Maybe, they were a person that always kept their house clean and now they can't clean the house, or they can't pay their bills, or, they can't cook a meal. Other reasons to refer would be behavioral. Maybe the person's having hallucinations and that could be, part of their dementia. Maybe they're anger and agitated. They're aggressive. Maybe they have inappropriate behaviors where they're combative or disrobing, again, wandering and pacing, and even substance use. We used to say alcohol use, but now we say substance use because of just a growing opioid epidemic, especially here in Summit County. So once you're trained to understand all the signs and symptoms of what you should be looking for as a gatekeeper, then your role is to identify that person and then refer them to us here at the health department. And what we need is their name, their address, a phone number if you have it, an age if you know it. I don't want to say we only see people over the age of 60 because we don't. We're seeing people who have cognitive issues that are in their 40s and their 50s, and we're seeing caregivers who are stressed out, that are also under the age of 60. So age is not a factor. We need your name and your agency, your contact information, and what the concern is. What is it that you identified that made you think that this person needed referred for additional assistance? Keep in mind, we're not adult protective services. So if this person is somebody that you're working with or you've identified that has a cognitive or physical impairment that prevents them from taking care of themselves, and you feel that they don't have capacity to make decisions and take care of yourself, you would be making a referral to adult protective services. If that's not something a person is willing to do, then we will go out on that case and we'll assess that situation. And if we need to make that referral to adult protective services, we will do that. And one of the things that we ask is, do you want to remain anonymous as the person making the referral? A lot of times the person making referral does want to remain anonymous because they have a relationship with this older person. Or they're a paramedic and they're going and they're picking them up off the floor every week. They don't want that person to feel like they can't call them for assistance. So they will say they want to remain anonymous. If you don't want to remain anonymous, it's easier for us to say, Sue from SUMA called us and thought you could use some assistance, and we're out here to see how we can help you. Our services are free to the older adult. It's part of our grant. Our grant covers our time. And when we're assessing that older adult, we're looking for the least costly, the least restrictive resources that are available to them to get them linked to support in the home. So what happens when we get the referral? We go on a home visit, and the program is set up to go on home visits and to do them unannounced. But because of COVID, we weren't permitted to do home visits for a long time. So what we ended up doing was just calling people over the phone and assessing them over the phone. Now we're going back out into the community, and we prefer to go out to the home because we can actually see how that older adult is functioning in their home, or that person who may have suspected dementia. We can see what the condition looks like. We can look at medication bottles. We can do, a much more comprehensive assessment in the home. We choose to do most visits unannounced. And the reason we do them unannounced is because if I call an older adult on the phone, typically, and it's happened even with those people that we've called on the phone, and I ask to come out, they're typically going to tell me no. They may have some suspicion that we're coming out to see how they're living, and that, there's always that fear of social workers coming into our home and taking us out of our home and putting us in a nursing home. And that's not what our focus is for this program. So we don't typically call, not unless it's, somebody that said call them. And the other thing is, when we do go out, if they don't let us in, like I said before, we can assess the outside of the home. If they open the door, does the home have odors that are permeating? We can assess the person, how they're dressed. And really, we can ask a few questions that give us an idea if we need to take a step further and refer that person to adult protective services. But if we get in the home, we're doing a comprehensive assessment. It may take us several weeks to complete the assessment, but the assessment is never completed because it is ongoing. What we're going to do is we're going to develop a plan of care with the older adult. We're going to start where the older adult is, or the person that we're providing care for. They have the right to self-determination. So if they say they just need transportation and we think they need doctors and Medicaid and whatever, we're going to start where they are. We're going to build a relationship with them and continue to plant seeds about the other resources. We're going to link them to appropriate community resources. And here's just a list of some of those resources that we're going to connect people to. We're going to provide case management services for these individuals for a minimum of 3 months. We pick 3 months because typically by the time you make a referral to an agency, somebody connects with that person. You know, if they're filling out paperwork or they have to determine eligibility, it could take up to 3 months, but many times we're in the home much longer than the 3-month period of time because, you know, we're reassessing and identifying needs as we continue to see that older person. I'm going to say on average, you know, this is a newer program, but I have a couple of clients, one specifically that I've been working with for about 14 or 15 months. And her needs were so complex. She was a person that lived alone with dementia, that we're continuing to get her connected to services so that she can remain safe in her home. She's safe, but she needs a lot of help. And she had no medical doctor who's seen her in years. So we just got her to the doctor. We don't terminate services with a person until we know that they're safe and that there are systems in place to support them and that they have the ability or somebody in their family that can call and connect them to services or follow up if they need assistance or if they're placed into a nursing home setting. So this is kind of like our little algorithm. What happens? We get the referral from the Gatekeeper volunteer. We do an intake for that, and then we make this joint visit. We did have a nurse. We don't have a nurse now, but if I need a nurse, I take a public health nurse with me, especially if there are complex medical needs associated with that referral. I took a nurse out with me a couple of weeks ago, and you know, it was good to have that nurse there. I try not to work, you know, out of my scope. If we gain access to that person, like I said, we begin the assessment process. We provide that case management. We continue to provide case management. And then once we feel that person has been connected and linked and is safe and will be able to access services with supports or on their own, we will discharge them. If we don't gain access, we will make 3 additional attempts, either by phone or in person, to gain access to the older adult person. We try to call every person who's made a referral to us to let them know if we got in or not. That was some feedback that we had received, you know, that we don't always know what happens. Keep in mind that if you make a referral to us, we can't share any information with you. It's confidential, not unless the older adult has signed a release form saying that we can share information. So typically what I would do is I would let the person making the referral know that we got in and that we're working with the person, or we didn't get in, and if they have any concerns in the future, to give us a call back. If you have any questions or want to know more about our programs, you can reach out to us. We have an email address for the program. So there's a few people that work on there, and we have a main line, which is listed there. So you can call and make referrals through the main line. You can send a referral through the email. But if you have any other questions, here's my direct contact information as well. So I'm just going to open up the floor for any questions right now.
There's a question in the chat from Tina. She said she was unclear about why resisting care would be a reason to refer. When are people no longer able to exercise choice in daily life? And she says she's asking for a friend.
Okay, so I think when we talk about resisting care, we're looking at, is the person capable and do they understand, you know, what the services can do for them? Yes, people have the right to say no, and my job is to determine if they have the capacity and understand the reason why they're saying no, to make that referral. So if you're not a social worker or a case manager and somebody says, you know, I don't want anybody to come in, you know, whatever to my house, or I don't want any help, but you're still concerned about that person thinking they need help, then that would be a reason to refer to us. You know, I had a person a few weeks ago that was very critically ill, and she refused to go to the hospital. We called the paramedics anyway because she's so critically ill, And, they did what they do. They asked her some questions. She was able to answer those questions. She was able to understand that she would die. She could die if she didn't seek medical attention. And they didn't take her. So, she still had that right, even though, we all thought she was making a bad decision. Any other questions?
Susan Fine has asked, are there gatekeeper services in Cuyahoga County?
There used to be, but there's not any longer. I think Cuyahoga County has, they have a Department of Senior and Adult Services. And so they used to have not a gatekeeper program, but they used to have a community resource department that was part of Adult Protective Services. So when they got a referral on somebody who didn't meet the criteria for elder abuse, those folks would get referred over to that community resource department. I haven't worked in Cuyahoga County for 7 years, so I'm not sure if they're still doing that, but that's what people would do in the past. And when I worked in Cuyahoga County, I had a gatekeeper program for 16 years at a local hospital. So I was happy to be able to start it here in Summit County.
And we've got a follow-up. Is there a gatekeeper program in Portage County?
I'm not aware of one in Portage County. No.
I had a question about it. So if you do an assessment with this, is it strictly limited to people with dementia? Like if you do your assessment and find out that there really aren't cognitive issues, would that care management be put in place, or would you?
No, we would still work with that person. I mean, any older adult could potentially have an issue with cognition. And so if we get a referral, we go out and we assess that situation. In a lot of cases, we talk to them about getting screened, with their doctor, getting a baseline, those types of things. Very few referrals end up where we don't have some issues with an older adult with dementia or some complex other issues. Those information and referral type things, we do connect them to services. We may not go out on them if it's just, maybe it's the older adult calling themselves. But the Gatekeeper program actually is a national model. It's been around for 30 or 40 years. So it's in many, many states across the nation. Japan, I think it's in Australia. So the concept is not a new concept. It's new here. A lot of gatekeeper models are in the West Coast specifically. They do a lot of their gatekeeper through their area agency on aging. It's just another component of what the local area agency does, is they'll get those referrals and do, a gatekeeper type thing. They'll train people to identify them and refer to them. I'm not sure that they go out necessarily, but they do long-term care support services, and they are the front door for aging. So it works well in those systems as well.
Are there any HIPAA type issues related to making a referral? Like if you're a EMS person or in maybe a doctor's office, are there any issues like that?
So people ask that question. A person that's making a referral out of good conscience are protected by the Good Samaritan law. So I think you can choose what you say when you make the referral to us, but we've gotten doctors' referrals where they've said what the diagnosis was, what the concerns are. It's not been an issue. We don't necessarily tell the person who's making the referral, and we don't go out there saying, oh, I understand you're a diabetic, blah, 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 blah. We're assessing to determine, and part of that assessment is to know if they know what their health history is and what their medications are and that, and sometimes they don't.